unfortunately, for us to know who to immobilize because they have fractures, and then to distinguish those from who has soft tissue injury or no injury and can undergo early mobilization. Historically, we were doing splinting and radiographic follow-up. Then MR came along, and everyone wanted to do MR on these. And CT is obviously very accessible in the ED, and so that's also been suggested as an option. And you can also find references to bone scans and ultrasounds in the literature as well. Unfortunately, the most recent meta-analysis of this was really long ago, from 2012. So this is, in the early days of CT, quality was not fantastic back then. But what they looked at was all the papers that have been published on occult scaphoid injuries, comparing follow-up radiographs, bone scintigraphy, MR, and CT in terms of diagnostic sensitivity and specificity. And I'll just sum up what their report said, and that was that follow-up radiographs will lead to a false negative rate of 9%. So 1 in 10 is still going to be missed on follow-up imaging. That MR is really the diagnostic study of choice in these patients because it has high sensitivity and specificity. Bone scans were not specific enough and could lead to overtreatment, and CT may not be sensitive enough, leading to undertreatment. But this was, again, before many studies had really looked at CT very thoroughly. So here's an example of an occult scaphoid fracture. This was the initial radiographs in this patient who fell from his bike. And even in retrospect, there's really just nothing here that would call out fracture. We do see this little lucency, but it goes across the capitate and the scaphoid. So it's probably artifact, and we don't see anything else concerning. Patient continued to have pain, and so they followed up with an MR at some point, and we can see that there is a non-displaced fracture here of the scaphoid pole, and also an injury over on the other side of the wrist as well. So ACR appropriateness criteria, back in 2013, the prior iteration of this, there was actually specifically a scenario related to occult scaphoid fractures. And you can see at that point, they said MR is great if you have it, but if you don't, you can cast and repeat radiographs in 10 to 14 days. In 2018, they actually took out the specific stem, so we don't have anything specific for the scaphoid, but we refer back to this acute hand or wrist trauma where the initial radiographs are negative or equivocal. So what should we do after that? And so again, MR, radiography, or CT are all basically on the list. So they really didn't come down very hard in the ACR appropriateness criteria as to what we should do. In the future, there are some options that may be out there for you to make this diagnosis with greater confidence. So dual energy CT might be useful. I've had access to dual energy CT for about a decade now, and it's really challenging, at least on the ones we have, to actually get small bone imaging. So bone marrow edema in a carpal bone or a tarsal bone is really limited in my experience. But if you have a really good scanner and you can get some useful information out of that, that may be helpful. Cone beam CT can also demonstrate these subtle fractures. Unfortunately, it is its own unique hardware, and so it's usually only available in ortho clinics and things like that. There, of course, may be AI algorithms that will help us pick up these fractures more easily. I don't think anyone's going to miss this particular fracture here, but maybe there will be some more subtle ones that AI can help us identify. And then finally, photon counting CT is this brand new emerging technique. We got a photon counting CT at Harborview about 6 months ago now, and we're still getting used to it. But it's a fantastic option for these kinds of cases because not only do you get super high resolution images, but you also get the spectral data that you want for dual energy imaging. So hopefully, at least at Harborview, we'll have an improved chance of making these subtle diagnoses of scaphoid fracture in an earlier setting using this technique. But that's going to be not prolifically available all over because it's such a new technique. All right, so scaphoid fractures, we really need that fourth view. If you don't have it and the patient has snuff box tenderness, you absolutely need to make sure that the clinician gets that fourth view. Some, even with optimized technique, will still be occult. And so what do we do with those? They should get either MR, if we have access to it, splinting and radiographic follow-up in 10 to 14 days, or if you think you have a pretty good CT scanner, you can try to do a CT on it as well. But trust those results a little bit less than the other types of imaging. Okay, case 3 is a 30-year-old man who fell. So what is the most significant injury present? Is it his ulnar styloid process avulsion, radial styloid avulsion, scapholunate ligament tear? Is there a dislocation, or is there a slack wrist deformity here? And so looking at these radiographs, there are certainly some fractures here, radial styloid and ulnar styloid. But most importantly, we see on the lateral view that there is a dislocation here between the capitate and the lunate. And given the alignment here, we'd probably call this a mid-carpal dislocation. So that's the most important finding in this particular patient. And then the styloid avulsions are just a small component of that. So let's talk briefly about intercarpal dislocations, whether or not they also have fractures. In general, these are where we see dislocation of the capitate from the distal lunate. Most commonly, the capitate's going dorsal, lunate, if it's going anywhere, is going volar. And we have these classic patterns that emerge. Although there is quite a bit of variability in the radiographic appearance of these, we do see some very classic patterns too. And then I will raise the possibility, or just bring up the possibility of instability where there is no dislocation either at the time of imaging because it was spontaneously reduced, or just because there was no dislocation, but they are unstable. So why do these classic patterns happen? There are these a number of ligaments on both the volar and dorsal aspects of the wrist. This is the volar view here. And the arrangement of these ligaments that are meant to hold the carpal bones in place creates an area that's quite vulnerable to injury right here at the top of the lunate. And it's through this space that these dislocations tend to happen. So the arrangement of these ligaments create what we call an arc of vulnerability. And when we transpose that onto our radiographic image, we can see that it frames the lunate here. So you can get pure ligamentous injuries, we call those lesser arc injuries, or you can get fractures that the ligaments of the bones that the ligaments attach to, and these are called greater arc injuries. And so if you look at the greater arc, it includes the radial styloid, scaphoid, capitate, hamate, triquetrum, and ulnar styloid. In 1980, Mayfield described this very nice sequence of dislocations, starting with perilunate, followed by mid-carpal dislocation, followed by lunate dislocation. And to get from one to the next, you had to disrupt some additional ligament or break an additional bone. And while that's all well and good and maybe accurate, the way that these occur in my mind is maybe more of a spectrum of end terminal appearance of these unstable injuries, because often we see more fractures with the earlier stage than we do at the later stage. I've also heard recently described that maybe the difference there is because of the magnitude and acuity with which the force is applied may preferentially injure ligamentous structures with high energy trauma as opposed to lower energy, maybe more bone related. In whatever case, though, you're going to see a spectrum of these. They're not all going to look alike, and some will have fractures and some won't. Okay. So here's just an example of why this spectrum idea, as opposed to a progression, is maybe accurate. So here we have some very grainy radiographs. These were from an outside hospital in a patient who has a dislocation. And we can say that the capitate's dorsal lunate is still in the radial fossa, so it's probably a perilunate dislocation. Patient was bundled into the ambulance and transferred to Harborview a few hours away. And at Harborview, after he got there, we see this radiographic appearance where now the lunate is starting to sublux out of the distal radius as well. So unless the medics were mean to the patient in the ambulance and tore an additional ligament, he probably was this way from the beginning. And we just imaged in two different positions, and so we see the difference manifesting on the radiographs for that reason. So again, the overlap here is a lot greater than you might imagine based on reading Dr. Mayfield's paper. Okay, so why is this topic in here? Well, at least in pretty old literature at this point, somewhere up to a quarter of these injuries are initially missed. So this is something we want to do better at. So start with our DP view. We want to make sure that all the carpal bones are in appropriate positions. And the way that we do that is to look at the three arcs of Gallula. So the proximal arc here goes across the proximal cortex of the proximal carpal row. The middle arc goes along the distal cortex of the proximal carpal row, and then the distal arc goes along the proximal cortex of the distal carpal row. And all of these should be nice, smooth, continuous curves, of course, not where the joint space is going through, but there shouldn't be a big gap or a big step off anywhere along those arcs. Then we're going to look at the articular surfaces and the joint space created between them. It should be fairly uniform, no more than 2 millimeters, except at the scapholunate where it can be a little bit more. Again, up to 3 is considered okay. And then the lunate should look kind of trapezoidal like this. We certainly don't want to see is a pie-shaped lunate like this. So pie-shaped lunate is a rotated lunate. And then lastly, we're going to look for any of those fractures along the arc of vulnerability. Now again, the pie-shaped lunate indicates a rotated lunate, as we may see in these various types of dislocations, but unfortunately it's not specific. So we can see it with just ligamentous findings, including VC, as in this case, just if the wrist is dorsiflexed, which was the case here, or in slack wrist deformities. So it is not specific for dislocation, but it does cue us in on the frontal view that something's going on. We need to check that lateral view to look at the alignment and the positioning of the lunate better. Which brings us to the lateral view. So we're going to look for that capitate sitting like a teacup in the saucer of the distal lunate. Particularly once we've identified a dislocation, we want to see that the long axis of the radius and its relationship to the capitate and lunate. So they should all line up, but if one is not in alignment or two are not in alignment, then that's how we described what type of dislocation is present. And then again, we're looking for any of those fractures along the arc of vulnerability. On this view, the most likely would be a triquetral avulsion. So let's work through an example here. We have a frontal wrist radiograph. Number 1, you'll notice a pie-shaped lunate here. And the proximal arc of Gallula is disrupted. Can't really track it in a nice smooth curve there. Similarly, middle arc of Gallula, there's a big gap in it, and the distal arc looks okay. Moving to the lateral view, we can see that there is definitely dislocation between the lunate and capitate. The long axis of the radius bisects the capitate still, but the lunate is rotated 90 degrees volarly. And so this is compatible with a lunate dislocation. And as is most frequently encountered, at least in my experience, there are no fractures here. So this is a pure ligamentous injury, even though it's the final stage that Mayfield described. Another example to work through here, we see on the frontal view that the middle arc of Gallula is disrupted. Distal arc looks okay. Proximal arc looks okay until we get to this displaced scaphoid waist fracture over here. And then moving to the lateral view, we again see dislocation between the capitate and the lunate. But now the lunate is still in alignment with the radius. And so this would be a perilunate dislocation. And this is the most common combination of findings where you have perilunate dislocation with a scaphoid waist fracture. So why is there no pie-shaped lunate here? Well, when we look at the lateral view, we can see that lunate's not actually rotated. So it's not completely a surprise that we may not encounter a pie-shaped lunate in this scenario. And here is the intraoperative spot image on this patient. So you can see scaphoid fixation and then reconstruction of the ligaments with these K-wires. So the reason I showed that image is because of the subsequent case. And so here we have a young patient who was in a motor vehicle crash. He's in his early 20s, I think. And we can see multiple fractures here across the arc of vulnerability. So 4 fractures across that arc of vulnerability. That's a lot of fractures. But when we go to the lateral view, there is no dislocation. So his capitate is still sitting in the lunate. He did not have any other radiographs showing a dislocation or even subluxation. And yet he went to surgery and it has the exact same image that the last patient had, indicating that he had instability and that they're reconstructing these ligaments. So this is a scenario that has been called the perilunate injury not dislocated, or PLIND injury. And it is unstable. It does require fixation, but you don't get the dramatic malalignment that we look for on the other views. The only clue on this radiographically would be if you see multiple injuries across the arc of vulnerability. So for these intercarpal dislocations, we really need that systematic review looking at the arcs of Galula, looking on the lateral view specifically for the capitate to sit in the lunate cup, and then checking that arc of vulnerability, all those bones framing the lunate, for any evidence of fractures. So more than 1 or 2 fractures is going to be a clue that this might be more of an unstable injury. And then we use the radiolunocapitate line on the lateral view to help us determine which of the names we're going to use for these dislocations, which probably have a lot of overlap. And just remember, a pie-shaped lunate is a rotated lunate. It does not necessarily mean there is a dislocation, and its absence also does not mean there's no dislocation. All right, moving now to case 4, 44-year-old who is in a motor vehicle crash. On the frontal view, we can see the joint space going across the CMC joints is not well visualized at the second and maybe third CMC joint levels. And so this is where the lazy M is too lazy to show up. All right, so we go to our lateral view. We can see the capitate here. You can see 3 of the metacarpals seem to be pointing toward it, but one of them has slightly a different angle and is pointed a little bit more dorsal. So this suggests that there's a CMC subluxation or maybe dislocation here. And while the numbering of this is difficult on this view, you could see based on the length of the metacarpals that this was probably the second digit here. And we also see some fragmentation here along the dorsal aspect of the distal carpal row. So this is possibly coming from the capitate, maybe from the trapezoid. So ultimately, this was a second CMC fracture dislocation. So CMC fracture dislocations are rare injuries. These are not common. It is possible that you won't encounter one. The problem is, maybe because they are so rare, they are missed the majority of the time. So if you're thinking about what the standard of care is, it's actually probably to miss these, but that's not what we want to do. We want to be better than that. So why are these injuries missed? Unfamiliarity with the diagnosis. Not knowing it can even exist means you're probably not going to diagnose it. And then also the quality here can be really challenging. So we're going to talk about quality issues for this diagnosis. So it turns out this patient actually had their car accident 1 month earlier. And when they presented at that point, the lazy M was intact. He was not too lazy to show up. And he had all 4 metacarpals pointing toward the capitate on the lateral view. So this is what we want to see, and this would have been called normal. He did have a fracture, and that was diagnosed at the base of the thumb, at the trapezium. And that was treated. But there was this other bone fragment here, which it's hard to know where the donor site is, or what the clinical significance of that was. But in fact, that was probably coming off of that same bone that we see the fracture on later. So if you do see funny looking bone fragments around the CMC joints, it's very important to think about the possibility that these are on the carpal side or the metacarpal side and maybe associated with instability, because I've seen a couple of these come back dislocated after not being dislocated initially. Okay, so how do we assess this joint consistently? So we're going to look at the dorsopalmar view, and we want to have the hand flat and held in the same plane as the wrist. Okay, you don't want any dorsiflexion or palmar flexion on this view. We should be able to see the joint space winding its way lazily across all 5 digits. It should look like a 1 to 2 millimeter joint space throughout. It shouldn't be wider, it shouldn't be smaller, and that's our lazy M. Okay, and if you can't see the lazy M on the wrist view, you want to look on the hand view, you want to look on the forearm view, you want to make sure you can see it somewhere. Because if you can't see it, it may not be intact. Also, just note there's really not a ton of osseous overlap here, a little bit in some of these joints, but not a ton. So that's another thing that may catch your eye. And then finally, if you look at the 3rd through 5th metacarpals here, the heads should all line along the same tangent as shown on this image. Okay, and then one more thing that has been suggested as a way to keep the evaluation here consistent is that the long axis of the 2nd through 5th metacarpals should all converge on a single point. It was described as 2 centimeters proximal to the radial articular surface. This one's obviously a little bit more proximal than that. So that's variable, but they should all converge on the same point. That's the key. And this is known as the metacarpal cascade lines. So if you have a dislocation, you may note that the 2 dislocated metacarpals in this case have a different orientation. And so that may be a clue or to help you figure out which ones are dislocated if it's still a question. And also note on this image that the 4th metacarpal head is not lying along that tangent. So there was some shortening here. There may be shortening there as well, but it's really just looking at the 4th metacarpal here. So you would expect the lateral view to be where we can actually make this diagnosis, right? So you go to lateral view and you look at the alignment of the metacarpals relative to the carpal bones, and we're looking for any subluxation or funny angulation here. Unfortunately, more often than not, we're going to get radiographs that are not like this and maybe more like this, which is overly pronated. This is the 1st metacarpal lying in front of other things. You could also see overly supinated images, or you can have flexion of the metacarpals if the text had the fingers kind of splayed out, which is great for the hand, but not great for evaluation of the CMC joints. So here you see different angulation between the 4th and 5th metacarpals than you do for the 2nd and 3rd. So with all these variations in alignment, it's not altogether surprising that it's a very challenging diagnosis to make, particularly with confidence. Here's a pitfall. So this was a patient looking at their wrist radiograph. We can see the lazy M here and here, but it fails through much of the CMC joints. But looking at the hand radiograph, we can see it. Okay, so this would be an example of where flexion on this view makes those joints rotate away from us, so we can't look straight down them on our X-ray, and we can't see the lazy M. But looking at the lateral view, we felt pretty confident that there was no dislocation here, and we could see the lazy M on other views. So this was passed appropriately. Another thing that may come up, so looking at this view, we see a lot of just osseous overlap here. And again, that might be might raise the question of, is there a dislocation here? And we really don't see the lazy M very well through the 2nd CMC. Looks better on the oblique view, but still a lot of bone here, just too much osseous overlap. So then we go to the lateral view, and you can see why there might be extra bone here. There's this hypertrophic change here along the dorsal aspect of the CMC joint. You can see the joint line actually going straight through it. And this is a known thing that happens, maybe not clear why it happens, but it does, where we get this extra osseous density back here, and it's known as carpal bossing or a carpal boss. This is a 3D reconstruction from the literature, or from online anyway, showing a carpal boss in 3D. And then I haven't ever had radiographs of my wrist, but I might have one because I have a little bit of a bony, excuse me. Whew. Sorry, I was going to sneeze. A bony bump along the dorsum of my hand. Okay, sorry about that. All right, so CMC fracture dislocation, super challenging. You really need to have a systematic review. Build it into your search pattern to look at the lazy M. If you don't see it on the wrist, make sure you can see it on a hand or forearm view. If you can't, you really need to make sure that lateral view is diagnostic. So if the lazy M is too lazy to show up, that's a problem. You can try to use those metacarpal cascade lines. Again, you have to kind of train your eye to make them. You might have to actually draw them in order to really know what they're showing. And then hopefully we can make the diagnosis off the lateral view. But again, that lateral view is so prone to rotation or angulation issues. And then finally, if you do see a fracture anywhere around the CMC joint, just keep that in mind, as it may be unstable and there may be more significant findings to come down the road, if not right now. And beware of flexion and carpal bossing. Okay, next patient had a serious fall. He's not conscious, so he can't really participate in the exam. But what is the most clinically important injury present on these images? Obviously, the brain is probably injured as well. But is it triquetral avulsion, midcarpal instability, radial head fracture, axial forearm instability, or ulnar styloid avulsion? So we can see evidence of many of these, but this is a wrist talk. So why am I showing a lateral elbow radiograph? Certainly there's this fracture dislocation involving the anterior aspect of the radius here, and in combination with the ulnar styloid process, maybe slight prominence of the distal radial ulnar joint and positive ulnar variance, this patient has high concern for axial forearm instability, also known as the Essex-Lopresti injury. He does have a triquetral avulsion, but it's not very important in relation to these other things. And sure enough, patient had confirmed Essex-Lopresti and underwent surgical intervention. So for the distal radial ulnar joint, it is this joint between the convex ulnar head and the concave sigmoid notch of the distal radius, and it is stabilized by the triangle fibrocartilage complex. And for the purposes of our discussion, the most important attachment here, attachments are the volar and dorsal radial ulnar ligaments, which attach at the base of the ulnar styloid process. So in order to disrupt your drudge or destabilize your drudge, you have to tear the TFCC. Unfortunately, we can't see the TFCC on imaging, and so this becomes a very difficult radiographic diagnosis unless there is frank subluxation. So dorsal, volar, or medial ulnar subluxation can manifest here, but it can be very challenging to figure out if it's there and real. So forearm and wrist rotation can hide it or mimic it. And unfortunately, sometimes instability is even positional. So it may look okay on the static radiographs, but then you put the patient in a different position and the ulna pops out. So how do we make these diagnoses? We look for the width of the drudge. 3 millimeters again here is kind of a catch number there. So just like the scapholunate interval, if that's more than 3 millimeters, that may catch your eye. If you go to the lateral view, we're going to be looking for basically where the ulna is with respect to the radius, okay? And if you have what's called a true lateral view, and we have to define that because there's lots of definitions of lateral views in the literature, but if you have a good lateral view, you can assess where the ulna is relative to the radius. So what we want is the scaphoid and the pisiform, their volar cortex, should be essentially superimposed. So we want less than 3 millimeters of distance between those cortices. Okay, as long as those are very close in location to one another, we can look at the dorsal cortex of the distal radius, the dorsal cortex of the ulna, and that should lie within 6 millimeters of one another. Okay, so if we have this scenario, then there is no evidence of ulnar subluxation, either volar or dorsal, on this lateral view. It could go medial on the frontal view, but at least on the lateral view, there's no evidence of drudge instability. All right, so the drudge is really hard to evaluate, as I've mentioned. So when should we think about drudge injury? So there are some typical injury patterns that are associated with unstable drudge. Please ignore the non-displaced ulnar shaft fracture here. So intra-articular or juxta-articular distal radial fractures, radial diaphyseal fractures, the classic Galeazzi injury patterns, and then any complex radial head injury. So things like dislocated radial head fractures, comminuted radial head fractures, just displaced radial head fractures. Any of those should raise alarm bells that we may be dealing with something more complicated. And then again, we may have very localized injuries involving the TFCC or its attachment. So if we see a fracture through the ulnar styloid base, that is a clue that we may have destabilized the dredge. So let's talk just a little bit more about those distal radial fractures, because upwards of a third to half of distal radial fractures will have injury of the TFCC accompanying them. And so it's not uncommon. We definitely need to consider it because the outcome is best if the TFCC is repaired along with the distal radius. So radiographic findings, 3 millimeters again for the widening here. I wouldn't say it's here in this image, but we look for 3 millimeters of widening. We look for a displaced fracture through the ulnar styloid base, which we are seeing, and fracture extending into the sigmoid notch of the radius. Now, unfortunately, these fracture lines are typically in a coronal plane, and so they're not going to be very easy to see on radiographs, more easily picked up on CT. And then if the radius is very short, or shortened, more than 3 millimeters, that is also associated with TFCC injury. On the lateral view, dorsal or volar dislocation of the dredge, again using that 6 millimeters between the dorsal cortex of the ulna and the dorsal cortex of the radius. Okay, so we combine associated injuries, we combine suspicious radiographic findings, and we may arrive at a situation where we're suspicious, not confident, in which case they can do physical or intraoperative exam for ulnar instability. If that's also inconclusive, CT or MR may be considered. So again, ACR appropriateness criteria, we do have distal radial ulnar joint here on variant 4. So CT, MR arthrography, or maybe CT arthrography. Here, there are actually some specific CTs we can do. So you can do a single position CT, which looks for fixed displacement or dislocation. But they've developed this thing called a 3-position CT, neutral, full pronation, and full supination, and usually do both wrists at once. And this can assess for positional instability. And so this is preferred workup for dredge instability. So here's an example. This is a young woman who was ejected from a car during a motor vehicle crash. She had just extensive soft tissue injuries, so physical exam was impossible in her. And the initial radiographs were read as negative. However, in retrospect, we can see that the pisiform is lying anterior here to the scaphoid. And so she's over-supinated, okay? Which means, if anything, her ulna should be anterior to her distal radius. And in fact, we see it's dorsal. So this is not a scenario you can get with rotation. Okay, this indicates that the ulna is dorsally dislocated. However, it looked really good on the frontal view, so hard to do on the lateral view because of all the soft tissue injury, and so it wasn't caught early on. And she ultimately went on to this 3-position CT, which shows fixed dislocation on all 3 views of the ulna. But it is possible that you could have just 1 or 2 of these views being positive as well. Okay, so MR is done to look at the TFCC specifically, looking for symptomatic tears. Unfortunately, there's a lot of degenerative defects that are not symptomatic, so they can cause problems with MR interpretation, and there's some specific MR imaging recommendations. Okay, so dredge instability, we need that systematic review, 6 millimeters of distance between the dorsal cortex of the radius and ulna and lateral view. Look for related injuries with high-risk features. So you really want to make sure they have wrist, forearm, and elbow radiographs. And then if needed for confirmation, CT in 3 positions or MR could be obtained. All right, our final topic is shown here. 49-year-old female bicyclist hit by a car. We see subluxation at the first CMC joint in the radial direction. So this is a gamekeeper's or skier's thumb. Gamekeeper's thumb technically is a overuse or repetitive use injury, whereas skier's thumb is the acute traumatic injury that we were seeing there. Both of these happen from forced hyperabduction of the thumb. So skiers get them because the pole pushes up on the thumb when the person falls. And the result is a tear or avulsion of the ulnar collateral ligament. Unfortunately, bony avulsions are only seen about 20 to 30% of the time, so a lot of these are soft tissue injuries and can be really challenging to diagnose, especially on radiographs. Unfortunately, if the diagnosis is delayed, then patients lose that thumb index grip strength, and this, of course, is very important for activities of daily living. And ED providers can easily miss these, particularly if they're inexperienced. And so it often falls on the radiologist to make this important diagnosis. So here are 4 different patients with a variation or a spectrum of skier's thumb injuries. So here, starting on the left, we see a pretty big fracture fragment, but non-displaced with articular surface involvement. Here we see a juxtaarticular avulsion, minimally displaced. Here we see a tiny little bone fragment, but very displaced. And then here we saw no fracture, but obvious subluxation of the CMC joint. Again, in 2013, there was specifically a stem related to gamekeepers or skier's thumb injuries, so radiographs or MR were equally okay to start with, but we don't have this variant anymore in 2018, so we are left with starting with radiographs and then proceeding on with additional imaging. So if you're specifically concerned about any of the finger joints, the MR or ultrasound is most appropriate after the X-ray is performed. So this was a patient with a radiographically occult skier's thumb. Looks pretty normal. And on the subsequent MR, we see the tear there of the ulnar collateral ligament. These are surgically treated if we have something called a Stenner lesion, which we'll show in just a moment. If the ligament or bone fragment is displaced more than 5 millimeters, or if you have more than a quarter of the articular surface involved. So these will tend to be more unstable and or heal poorly. So what's a Stenner lesion? So usually you have your ulnar collateral ligament, and then you have something called the adductor aponeurosis lying on top of it. And when that, if that flips down into the defect, either the bone or ligamentous defect, it will prevent healing and lead to chronic instability. So this was a young woman, again, negative radiographs, looked normal, went on to MR. And here on the coronal stir image, we see the ball on a string or yo-yo on a string pattern of a Stenner lesion. So this is the balled up ulnar collateral ligament down here, and this is the adductor aponeurosis interposed into the defect. So it kind of looks like a yo-yo on a string. And so this is classic and is a Stenner lesion, and these require surgical intervention. It's for the theoretical risk of inducing a Stenner lesion that we want to avoid doing or recommending joint stressing in this area. You can detect Stenner lesions on arthrograms, MRI, or on ultrasound. And just in case you weren't sure, you can avulse the radial side. It's much less common to get radial collateral ligament avulsions. In some studies, maybe 1 to 10 is the ratio of between radial and ulnar collateral ligament. But in certain populations, it's been found to be much more common. So in football players in the US or in military personnel, they for some reason have a higher propensity to injure the radial collateral ligament. Unfortunately, the diagnosis is more often delayed over here, and as a result, they're more likely to need internal fixation. Okay, so skier's thumb injuries, we look for the fracture or bone fleck at the ulnar aspect of the first MCP joint. But remember, that's only 20 to 30% of cases. So if you see any subtle subluxation, it could still be a skier's thumb injury. And if the radiographs are equivocal, then MR is the next best step. Unless, of course, you're doing ultrasound of these in your institution, and we do not recommend stress imaging. So to summarize, radiographs are usually sufficient for wrist trauma, but you need to have a systematic approach. If you see gapping between the scaphoid and the lunate, the Terry-Thomas sign, that's indicative of scapholunate association. If you see a pie-shaped lunate, just remember that's rotated. It's not necessarily dislocated, and you can have dislocation without it. If the lazy M's too lazy to show up, remember that could be CMC dislocation, but it could also be wrist flexion or carpal bossing. If you have 6 millimeters of distance or greater between the dorsal cortex of the ulnar radius and radius on the true lateral view, consider dredge and subluxation. And then finally, if you hear things like snuff box tenderness or fall on an outstretched hand, thumb hyperabduction, etc., be extra vigilant because these have a very high rate of being radiographically occult. So here are some references, and thank you so much for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Sanj.